Hi, this is Professor Grodman, and this is a review for Exam 3 in Psychology 245 Abnormal Psychology. Exam 3 will cover chapters 11 through 16. 11 deals with substance related disorders and also impulse control disorders. Chapter 12 with personality disorders, schizophrenia in Chapter 13, neurodevelopmental disorders with 14, neurocognitive with 15, mental health services, specifically with regard to ethical issues, 16. Okay, in terms of substance-related disorders, just a few to run down. Alcohol use disorder, where there is typically excessive use of alcohol, with not only excess but with a great amount. So it's not only the regularity, it's also the amount. And there is some impairment in terms of psychological or social functioning. But there's not physical dependence. A person doesn't go through withdrawal or need more and more to get the same effects from the alcohol. That would actually, that last phenomenon or last condition is referred to as tolerance. Now, a more biological condition is referred to as alcohol withdrawal, that it affects a person psychologically and socially, but also there's a biological dependence, so you do have withdrawal. Some of the data on alcoholism suggests it is more common in men. Adult children of alcoholics are more likely, about 3 to 4 times more likely, to be alcoholic. And the actual duration, the average duration of alcoholic behavior in terms of the actual consumption of alcohol and that the behavior associated with that about 10 years. Okay. Some other categories of substances. Caffeine, which can be addictive, just a couple caffeinated cups of coffee a day. So that is a caffeine-related disorder. Cannabis or marijuana is not considered physically addictive, but psychologically. So that would be cannabis-related disorders. We'll just speak about it in terms of one sort of singular description. Opiate-related disorders, examples of opiates which reduce pain and provide some degree of euphoria even. Examples include heroin, morphine, and opium. Stimulant-related disorders increase arousal, reduce appetite, can be addictive, an example being cocaine. Moving on and talking about impulse control disorders, issues with impulse control, of course. Intermittent explosive disorder is an example here. Episodes of aggression episodically. This is more commonly associated with children, but I believe it can be a designation that is given in adulthood. And there is often assaultive behavior on destruction of property, and there can be aggression toward others as well. And there is an intermittent or episodic aspect to this. Another disorder that is, this one actually is more specific to childhood, oppositional defiant disorder, in which a child acts out in one setting, either home or school, but it's not cross-situational. It's either one or the other. If that disorder becomes more pervasive, the behavior, and becomes cross-situational for an extended period, 6 or more months, this is referred to as conduct disorder. It's sort of the precursor to adult antisocial personality disorder. An antisocial personality disorder, and we'll go through this in just a second, again, with personality disorders as we go through, I think, the 10 or 11 of them that we talked about, LRON. This has to do with a violation of the rules of society, with a lack of conscience, lack of anxiety, a disregard for others, and often a history of conduct disorder in childhood. Just to back up, I just want to mention one or two more things regarding substance abuse, the terms you should know. You should also make note of something called a dual diagnosis. This is when you have both a psychiatric and a substance abuse diagnosis. It's pretty common. So let's, for example, major depressive disorder and alcohol use disorder, alcohol withdrawal. Those would be commonly coexisting with one another. They commonly coexist, or that's also referred to as they're commonly comorbid. In terms of the treatment of substance abuse, if there needs to be detoxification, that's inpatient treatment. often followed by outpatient treatment with a counselor, either someone who is a drug and alcohol counselor or a therapist who specializes in another discipline but works at least some of the time with people who have substance abuse issues. And many times it's a multimodal treatment. Someone's an outpatient treatment with a therapist, and they're also in a 12-step program like Alcoholics Anonymous or Al-Anon. So it's often the combination of those approaches. It should be noted that the goal of substance abuse treatment is often abstinence, just not doing it, because this is sort of the disease model, that it is biological. There is a vulnerability that people have, some people have at least, to these substances, and that to sort of think that you can drink or engage in other substance use moderately is often just not the case. It's not just not a valid assumption. So the goal is for that individual, once they've begun treatment in one of the aforementioned treatments, to be abstinent. And when they look at this over the course of a long period of time, there is a lot of relapse. For example, 1 year, about 50% of people report relapse who have one of the aforementioned, or maybe more than one of the aforementioned substance abuse issues. Just to finish that section off. All right, let's go back into our discussion, or at least we referred to antisocial personality. That's the first personality disorder we'll talk about. But these have to do with long-standing maladaptive behavior patterns. Antisocial, probably the most serious because of the damage it does to others, that this is a person who's acting out against other people aggressively, or sometimes they're doing it in a deceitful, dishonorable way. Maybe you might refer to as a more white-collar manner, but still there's a lot of destruction that is done. In a more aggressive sense, with antisocial behavior, we're talking about aggression to others, cruelty to animals, vandalism, truancy. You get a sense here, lying, deception. So, pretty serious disorder, disproportionately common in men. As noted before, lack of anxiety, lack of conscience, lack of remorse. So you can just hear how many different and significant characteristics are associated with this, and it's also very hard to treat. Just generally speaking, personality disorders are hard to treat. Medication therapies work in terms of symptoms only, but they don't really address the underlying character structure of the person. And with antisocial, treatment is often not something that is voluntary, that it's often mandated. Someone gets caught for a crime and then they're put on probation, and counseling is a component of that, or the requirement. And these are often very resistant patients/clients. All right, just continuing on with our discussion of personality disorders. We have borderline personality, where it's not a descriptive term. It used to be associated with borderline psychosis. Does not have to deal with that now. Has more to do with a poor sense of identity, difficulties having relationships with any moderation. It's either you love someone, there's idealization, or you'll split on them, the term splitting, and that relationship is severed, and that person is devalued. So they talk about splitting, going from idealizing someone, almost immediately, to splitting with them in not a very long period of time. There's a real difficulty here with sustenance with relationships, sustaining relationships. So we've discussed antisocial, borderline. Again, these are two of the more severe personality disorders. Schizotypal, which is both a personality disorder and a subtype of schizophrenia we'll talk about, is considered also a severe personality disorder. Odd, eccentric thinking, difficulties in relationships. Often this person looks unkept, really difficulties interpersonally, but they're not quite to the point of psychosis, but they're very close. And there's a theory that if they are stressed, if sort of pushed to the limits, in a sense, they probably become psychotic. Additional personality disorders. A person who's flamboyant, but yet superficial in their relationships and has difficulty with intimacy. A histrionic person, very attention-seeking. A schizoid person, someone who is detached from others, unmotivated to be social, can present in a very coherent, reasonable manner, just is disinterested socially. This gets in the way often of their lives, even professionally speaking. Passive-aggressive personality disorder, dealing with difficulties with assertion and aggression and expressing hostility, and it's done so indirectly, i.e. showing up to a party consistently or showing up to things consistently late and getting other people upset with you when in fact you're expressing your anger toward them arguably by engaging in this indirect form of hostility. Dependent people or dependent personality disordered folks tend to have difficulties with assertion, being independent, making autonomous decisions, being alone. It's considered a less severe personality disorder. I'm not going to ask you in terms of which is severe, which is less severe. I more just want you to sort of know each of them and some of the basic characteristics associated with each. Avoidant personality, the avoidance here has more to do with the social arena. And unfortunately, when we avoid, it's often negatively reinforcing. Remember that term, it takes away a negative consequence, and that strengthens or at least maintains the behavior. We've heard a lot on the news about narcissism and narcissistic personality disorders, people lacking empathy and feel entitled and have an exaggerated sense of self-importance called grandiosity, exploitative, envious, a lot of E terms here. Males are more likely to be narcissistic. Paranoid personality disordered people are not psychotic, but they are overly suspicious of others. And it gets in the way of the quality of their life and their interactions. Obsessive compulsive personality disorder is distinct from obsessive compulsive disorder. These are folks who tend to be neat, perfectionistic, have difficulties with spontaneity. Coordination, organization is the key, almost to a fault. And this gets in the way of their functioning, and it's that excessive, that extreme. That's obsessive compulsive personality disorder. Let's move on to chapter 13 in schizophrenia. Some basic points. The most prominent symptoms of schizophrenia are hallucinations, sensory processes that other people don't experience, and delusions, grossly distorted belief systems. These cannot be the result of something drug-related or medical. It has to be an organic process to be considered schizophrenia or schizophrenic. Other symptoms or secondary symptoms of schizophrenia include social withdrawal, lack of motivation, poor hygiene, tangential thinking, going from topic to the topic, very flat emotionally, or it's called flat affect. Mostly everyone does not have all these characteristics. It depends on the subtype. Actually, one of the higher functioning subtypes of schizophrenia used to be called paranoid. It is now referred to as delusional disorder, where the person is delusional, but they actually present reasonably well. They can tell you a story with a beginning, middle, and end. If someone is a disorganized schizophrenic, they can't do that. Their thinking is very tangential, very going from one topic to the next without any clear fluidity or transition from topic to topic. They also tend to be disheveled and may not shower and look like there's something that is problematic. Schizotypal personality disorder, as we mentioned before, odd, eccentric, on the sort of verge of schizophrenia. They used to call this simple schizophrenia. There's also a subtype of schizophrenia referred to as schizoaffective disorder, where there is both depression and psychosis. The age of onset of schizophrenia, typically 18 to 40. Etiology, well, it has something to do with an excess of dopamine and deficiency of serotonin. It does run in families. If you're a child of someone who's schizophrenic, your chances go from 1% to about 10%. Both parents, about 40%. There is a genetic component. Schizophrenia also can result, based on research, in reduced longevity due to multiple factors, including the side effects of the medication, weight gain, which is one of the side effects, suicide, poor access to health care, and fewer social supports, which is often, unfortunately, tied in or associated with schizophrenia. Treatment of schizophrenia traditionally is medication, antipsychotic drugs, along with supportive psychotherapy. Some adjuncts to treatment include hooking that person up with a case manager to help them with insurance, getting hopefully housing, vocational supports. All these supports are important in terms of improving the quality of life and functioning of someone who's been diagnosed and seems symptomatic with schizophrenia. Okay, so we're going to go from schizophrenia to neurodevelopmental disorders. We just talked about this recently in class. These are disorders which affect development to differing degrees. ADHD having to do with inattention, excessive activity. With a specific learning disorder, there is some impediment to learning in an otherwise bright person, and often associated with this is frustration, anxiety, or depression. So that's why it's in the DSM. Autistic spectrum disorders, of course, very well known as something that affects development, social, emotional development, at the low end of IQ, linguistic development. There's a real range here. At the lower end, it's often associated with an intellectual disability / retardation. At the higher end, people who are bright academically, intellectually, but tend to be socially and emotionally way behind their peers. Autism is diagnosed about 4 times more likely in males than females. In terms of the notion of intellectual disability, also referred to as mental retardation, this is someone who pervasively scores below average, way below average mainly. And so it's not a specific impediment, it is broad. And a diagnosis is based not only on an IQ below 70, but also issues with adaptive functioning. That person would have a low IQ below 70, but compared to their equally aged peers, would be struggling in terms of their day-to-day life and activities of daily living. Moving into chapter 15, we just really focused on one disorder, that is major neurocognitive disorder due to Alzheimer's. Alzheimer's is a progressive neurological disorder which affects primarily memory. Remember, there are other symptoms like the lack of inhibitions, with aggression, with sexuality. Dementia is a broader term than Alzheimer's. It really speaks to memory loss. Alzheimer's is the most common subtype of depression. With Alzheimer's, there's a loss, biologically, a loss of the neurotransmitter acetylcholine and a loss of neurons in the hippocampus, part of the brain structure dealing with memory. And the treatment of Alzheimer's, there are some treatments which slow down the loss of this aforementioned neurotransmitter acetylcholine. Psychotherapy can help to some degree, but really it would have to be in the very beginning stages or even, really very early on, because at some point, if the person is progressed, they're not going to benefit from it. So it's really only in the beginning that psychotherapy helps for the individual, and more so later on with the family. Finally, we're going to talk about ethics, and we haven't even discussed this yet in class. We'll be doing so next week. The practicing psychologist is expected, this is chapter 16, or material relating to chapter 16, is expected to practice in an area of competence. That is, they have both experiential and academic training. That they not engage in something called fee splitting, that's paying someone for a referral. You can't do that. That's considered unethical. I don't know if that's not really illegal. A lot of things are unethical, but they're not illegal. We'll get into that. In terms of confidentiality between a client and a therapist or a psychologist, yes, things are confidential, except there are some exceptions. If someone's going to hurt themselves or someone else, you have a duty to warn, a duty to supersede that regard for confidentiality, and also report any evidence of child mistreatment. Psychologists and therapists are expected not to have dual relationships with clients. That is, you are not expected, and really is forbidden in a sense, to have both a personal and professional relationship. You also should represent yourself in a way that's clear and honest in terms of your credentials. Again, as I said before, many things are considered unethical, but not illegal. Representing yourself as a licensed psychotherapist is considered unethical. Why? Because there is no such term, but it's not illegal. Practicing psychotherapy really without a whole lot of training academically or experientially, well, that's not probably a smart thing to do. It's not ethical, but it's not illegal. And as I guess if an adult client had a relationship that was consensual with a therapist or psychologist that was romantic or sexual, that would not be illegal, but would be considered unethical. So that sort of does it in terms of our review for exam 3. And again, we've covered chapters 11 through 16. The exam will be multiple choice in nature. Continue following along with LRON. We're going to do a review on LRON as well and go through your notes in the textbook, and this should be of great help to you. Take care.